So this is, so eventually, so what really comes out of it? In the sense like, what are we finally producing? What is like at a broad 3000 feet level, what are we giving? And this is what I call my elevator pitch about ABDM. If I were to say what Ayushman Bharat Digital Mission does, it basically does three things. One, it enables interoperability in health data through health information exchanges. So it could be your personal health records, it could be for disease surveillance, it could be for anonymized data, for large data sets, for machine learning, etc. It enables, it creates an environment where data is shared from point A to point B in a safe, secure and simple manner. The second is enabling interoperability in health claims. This comes to the case when we talk about going for universal health coverage. As we know, at the end of the day, there has to be some form of insurance, some form of payer provider mechanism, so that we are able to cover everybody right from primary care to secondary to tertiary. So how do you make this today's insurance claims process more interoperable? And lastly, enabling interoperability in services. So today, for example, we all have the example of Amazons and Flipkarts. You want to buy something on Amazon, the seller has to be on Amazon. On the health side, there are applications such as Practo. You want to consult, avail a service in Practo, you have to be on Practo and your doctor has to be on Practo. So there's no talking between you, Practo and M-Fine, or Practo on Tata 1mg or something. So another thing that ABDM gives is interoperability in these health services. How can you make sure that there is, you as an individual are using an application that you like, and the provider as a provider is using an application that he or she likes. So based on this, there is an interoperable talking between the two, so that you can discover services, you can book the services, and you can avail and fulfill your services. So this is how the tech stack looks like. This is like the one slide that gives you about how the whole technology architecture sits in. And this, you need to look at this stack from the bottoms up. At the very bottom are digital public goods that we have created as a country. The first one, the cross-domain digital public goods, Aadhaar, UPI for payments, e-sign, DigiLocker, and the most important part of this whole thing, the consent artifact. I have one slide on consent artifact. I'll talk about consent artifact in more detail, but in a nutshell, the whole idea about consent artifact is whenever information is exchanged from point A to point B, it has to be with the specific, informed and free consent of the individual for a particular purpose. So this consent artifact allows, this consent artifact is a creation of MeitY, and it's a digital artifact which runs on Aadhaar, and this actually helps an individual to give granular consent as to what happens with his or her data. And other digital public goods are the registries that I was talking about. First and foremost is the ABHA, which is called the Ayushman Bharat Health Account. In other words, it is actually a health ID. Where you avoiding using the word health ID, because the moment ID comes in, there's a lot of personal and privacy connotations to it. What we are saying is this is simply a number. This is simply a number. You get a number when you cross a toll booth. You get a number when you go to a restaurant. You get a number whenever you do any transaction. What we are saying is this is a number that is given to you, except that the underlying authentication for this number is Aadhaar. So it is like your digital identity is verified using Aadhaar, and on top of that you have this number. Essentially, instead of using Aadhaar, because of the lot of the kind of restrictions that have been placed on Aadhaar, we are using ABHA. And then there are registries for healthcare professionals. When I say professionals, it includes doctors, it includes nurses, paramedics, Ayurvedic practitioners, yoga, Sova, Rigpa, and Unani, all the practitioners, and also allied healthcare professionals, ANMs, ASHAs, Anganwadi workers, etc. Anybody who is present in the healthcare ecosystem. And then healthcare facilities, again, an all-encompassing registry of facilities. And one more thing, the thing about health professional registry is every professional in that registry is verified by the authority which has the authority to say that, which has the mandate to say that this professional is actually an authentic professional. For example, medical councils for doctors, nursing council for nurses, dental council for dentists, etc., etc. So it's about, again, this is again a voluntary registry. You as a doctor can decide to be part of this registry and make your data available for the digital ecosystem. So once you enter and once you say that I am a doctor, I am an MBBS doctor, have done my degree from so and so, it is verified by the council. So that is how we are saying that we are creating registries that are already verified, that could be used by anybody in the ecosystem. That is why this is a public good. Similarly for health facilities. Any health facility, hospital, nursing home, lab, diagnostic center, physiotherapy center, any center that has to do anything with health. These are again, there are verifying modules where there are district level verifiers and state level verifiers whose sole job is to ensure that any information provided by saying that I am a doctor or I am a hospital of X number of beds and I have these many specialities, this is verified. On top of this come the services layer and the gateways and the protocols. Again divided into those three things. First one, the unified health interface, which I said, which enables interoperability in services. You should be able to search for a service, book that service, pay for the service, and avail the service. And then this entire thing is based on protocols which the NHA has developed in consultation and in collaboration with the larger development community. And you can actually all see this this is all on GitHub, in fact. So this is not something that government has internally created. This is created in consultation and in collaboration with the industry. Similarly, with the health information exchange, the idea is to ensure health data sharing with consent. And then what kind of health data is shared, I'll go in a minute briefly. The basic idea is to have that there is a provider, there is a user, and there is a owner of the data. So nothing goes from provider to user without the consent of the owner. This is what the health information exchange does it. And then the claims exchange, like I briefly mentioned earlier, it is again a similar thing where it allows for a flow of health claims data from the providers to the payers and the processing information back from the payers to the providers. So the protocol that is required, A, for transmitting data and B, for doing the entire communication, is developed by NHA in collaboration with insurance players, hospitals, technology providers, and this is again an open standard and is accessible by everybody, and anybody who wants to be part of this ecosystem would actually be following these protocols so that they are part of the gateway and start sending their information. As by virtue of PMJAY, government is the biggest insurance provider these days. We provide insurance to almost 62 crore people as part of the Ayushman Bharat Digital Mission. That is what happens on the PMJAY IT platform. In fact, we are serving 40,000 admissions or patients every day, and it amounts to close to 1.2 million health episodes every month. So that is the kind of thing that is going on. So apart from that, there are other players. It could be Max Bupa, it could be Star Health Insurance, it could be Apollo Hospital Software, etc., etc. So this is what the end user will see. So this is how the tech stack looks like.